Lyme disease is a disease that was discovered relatively recently, and it happened in 1975 in town of Lyme, Connecticut, and that's where the name came from. It's more prevalent in the Northeast and has become truly the most common tick-borne disease in the United States. So when Lyme disease is diagnosed, it's usually a consequence of tick bite, and tick actually does not cause the Lyme disease, but tick is a vector and a carrier of the Borrelia burgdorferi bacterium, and ticks can transmit Borrelia burgdorferi to humans. It can take relatively long time for bacteria to incubate. It can on average take from 3 to 32 days, but sometimes it may take several months. Bacteria can affect any organ and can cause variety of symptoms, can cause flu-like symptoms, constitutional symptoms such as chills, fever, malaise. Patient may develop arthralgias, but the most characteristic sign is the bullseye, which is a circle, reddened circle with a light colored center, and it will appear within days or weeks. So stages of Lyme disease, first of all, bullseye rash will appear, and it's very characteristic sign, and circle with a lighter center. After that, patient may start developing cardiac and neurologic manifestations. At the second stage, patient may develop cardiac and neurological manifestations, and patient may have complaints of chest pain or even ribs, soreness, rib soreness, shortness of breath. Patient may complain of palpitation, may develop arrhythmias, cardiac blocks, murmurs, which may occur secondary to valvular prolapse. Certainly diagnostically, cardiac echocardiogram may be necessary in this case, and neurological symptoms may start as well. So twitching of the face, patient may have spontaneous tremors, Bell's palsy, development, facial paralysis, paresthesias, headaches, confusion, cognitive difficulties, difficulty concentrating, reading, poor short-term memory, disorientation. Multiple sclerosis is a disease of degeneration of myelin sheaths in central nervous system. It is the most common case of neurologic disability among young and middle-aged adults, and the typical onset is between ages 20 and 45. There is some genetic component in multiple sclerosis inheritance. However, there is no direct inheritance, but it's been suggested that second and third degree relatives of person with multiple sclerosis are at increased risk of developing MS, and when we study twins, we see that there is 25% concordance rate if in monozygotic twins. when demyelination of subsequent degeneration of neurofibers in SNS happens, the patient may start experiencing symptoms. And what happened when the nerve is demyelinated, the nerve does not conduct electric signals properly and may have different conduction abnormalities. These abnormalities can measure by the tests, and it may measure the test may measure conduction velocity changes, decrease, or conduction block, and this may depend also on the place of the lesion and how long or how big is the lesion. Again, the abnormality of demyelination would happen. It's disappearing or slowing down the signal. And imagine that wire, electric wire that has isolation on it, that feeds your light bulb on your desk. The isolation was stripped and it lays in the water, very dangerous condition. Don't try it at home. But what happened, there is a chance that the electric signal don't get to the light bulb to light it up, and the signal, the electricity will be lost and will be conducted through the water. So same thing happens in multiple sclerosis. The signal either will slow down or completely will be blocked. So this is an autoimmune disorder, and the lymphocytic invasion of the lesion occurs when demyelination occurs. At the same time, lymphocytes may invade the lesions. So there is some type of evidence that there is antibody-mediated damage and to the myelin proteins, the proteins that build or that are vital parts of myelin. So when you look at the nerves, you will see hard or sclerotic patches, and you also would see in white matter that these patches are available, visible, and you don't need a microscope to see this. On autopsy, it's possible to see those, and myelin breakdown, you can see that those patches, and some call it plaque. They can appear anywhere in the brain, in brainstem, cerebellum, even spinal cord, white matter. If the plaque is fresh, you may see the evidence for active myelin breakdown. MRI is one of the ways to diagnose and evaluate for MS, and it may show two types of lesions or two stages of them. It may show that there is some inflammatory component, and that's the stage 1. And in second stage, the formation of the scar occurred of the demyelinated nerve. So basically the nerve's conduction again will be destroyed, and it will not be possible to conduct the signals normally. Clinically, what happens, the patient will again develop neurologic symptoms, will have speech and swallowing problems, visual problems because optic nerve is affected. There may be difficulties with gait, and there may be paresthesias again, disturbance of visual field, diplopia, and progressively patient may have worsening. So there are several types of multiple sclerosis. So relapsing remitting form of the disease is characterized by episodes when patient will feel and will present with acutely worsening symptoms, and after that patient may have some relapses, fairly stable periods of time. Secondary progressive disease will involve a gradual deterioration, neurologic deterioration, and there may be or may not be relapses, but in secondary progressive disease the relapses are not that common. And in primary progressive disease there is continuous neurologic deterioration from the time that symptoms are started. So again, there are three types. Relapsing remitting, patient may have episodes of acute worsening and then getting in stable plateau phase. Then after that another worsening. There is secondary progressive disease, which is gradual worsening with possibility of relapses. And the third type is primary progressive disease, which is a continuous neurologic progressive worsening of the patient, unfortunately, from the time that symptoms started. Amyotrophic lateral sclerosis, it's one of the most devastating neurodegenerative diseases, and it's also another name for it, Lou Gehrig's disease, after a famous baseball player named. And this is a disease of people in their late adult years, 50s and 60s, and the disease is very progressive, and usually from the time of onset of symptoms it takes to approximately 2 to 5 years to death. So what happens and why the disease has this name? Let's talk a little bit about this. It's a death of lower motor neurons that occurs, and when the lower motor neurons dying, at the same time the denervation of course occurs, and there are no nerves connected to muscles, the muscle mass or the muscle fibers shrink, and so muscle fiber will present with atrophy. This type of atrophy, secondary to disease of the nerves or death of the nerves or denervation, will be called amyotrophy, and that's why the disease's name is amyotrophic lateral sclerosis. The term lateral sclerosis reflects the fact that nerve fibers in lateral columns of white matter of the spinal column are affected and lost. At the same time, disease does not affect the intellectual abilities, the regulatory mechanism of coordination and control of movement, and sensory systems. The neurons of ocular systems are also parasympathetic neurons, and they are also basically ocular mobility, and the parasympathetic neurons in the spinal column also spared. The cause again is uncertain. there is some familial history, and it's a very small share, relatively small share of affected patients, but otherwise it's not really determined why the disease happens. And there are several mechanisms of ALS occurring, and there is possibility of injury to the nerves through glutamate gated ion channels, which will be distinguished by sensitivity to N-methyl-D aspartic acid. But again, it's one of the theories, and there is no certainty what causes the disease. There is autoimmune source also described or suggested, but disease at the same time would not respond to immunosuppressants, so possibly it's not autoimmune. But again, there is no cure really for the disease, and the care basically palliative. The patient will be exposed to rehab techniques, so patient may cope or may maintain the independence as longer as possible to prolong the survival times, but unfortunately there is no therapy, no cure for the disease. There is a drug, it's a anti-glutamate drug, again, and it's named Riluzole, but Riluzole is it's approved by FDA for the treatment of disease, but unfortunately the use of drug prolonged the survival only by 3 to 6 months, and they did trials, but it's already approved drug, so hopefully there will be something else on the market soon. But again, the take-home message about this, the atrophy of the muscles, the disease also will not affect the intellectual abilities at all, but symptoms of ALS will be a result of muscle deficits, and patient may experience such consequences as dysphagia, dysarthria, and dysarthria doesn't have anything to do with joints. It's inability to talk or articulate the speech, and dysphonia. Again, in rehab evaluation and treatment, it's important to involve the entire healthcare team, and by healthcare team I mean not only nursing and medical staff, but also auxiliary services such as speech therapy and physical therapy. Again, the goal is to prolong the survival time, or which is better, to provide the quality of life, to maintain the quality of life, not just prolong life. Neuropathies are peripheral neurosystem disorders. And neuropathies, truly, it's not a single disorder, but it's some type of collection or cluster of disorders. And neuropathy occurs when... So, talking about Guillain-Barré syndrome, this is an acquired inflammatory disease. And another way to describe the Guillain-Barré syndrome is as an acute immune-mediated polyneuropathy. So Clinically, we can define it as rapidly progressive weakness of the limbs and loss of tendon reflexes, and technically the Guillain-Barré syndrome will be the most common cause of acute paralysis. And because currently that's the Guillain-Barré syndrome, but of course in the past it was poliomyelitis. There are several types of Guillain-Barré syndrome, which at this time we will focus on main type of the syndrome, and which we will be talking about Guillain-Barré syndrome that has an immune component. So in Guillain-Barré syndrome, some type of exposure to a virus or an offending agent occurs, and the studies done in epidemiology, they linked the infection to Campylobacter, cytomegalovirus, Epstein-Barr, and Mycoplasma. And majority of the patients will report that they had flu-like illness prior to the onset of symptoms. And some patients will have antibodies against gangliosides, which in some cases it would be consistent with infections with Campylobacter. So what happens symptomatically? There is progressive ascending muscle weakness of the limbs, and it will produce a symmetric flaccid paralysis. Paresthesia will occur, and at the same time loss of loss of motor function. Progression is relatively fast, but it may vary, of course, the speed. Disproportionate involvement of upper or lower extremities may occur, and paralysis in ascending case will be progressing upward, and there is significant number of people with Guillain-Barré syndrome which will present with involvement of respiratory muscle. Autonomic neurosystem also can be involved, and when we have autonomic involvement, we are exposed to the dangers of cardiac arrhythmias, and also the symptoms like autonomic dysfunction symptoms such as sweating and facial flushing, urinary retention. But at the same time, patient with autonomic dysfunction will have postural hypertension, or orthostatically you will get different numbers, and also patient will have quite significant amount of pain in some cases. It's a medical emergency, Guillain-Barré syndrome, but at the same time it's very treatable. Approximately 90% of people affected will achieve full recovery, but the problem with this, and there is no problem really with this, but it's the duration. Unfortunately, recovery takes up to 1 year to fully recover, and sometime patient will require ventilatory support to treat Guillain-Barré because of and also support of other vital functions, and patient may need supportive care to prevent skin breakdown, thrombophlebitis, and again, the treatment is mostly supportive, and also ventilatory supportive involvement of respiratory muscles is present, and at that time patients will require ventilatory assistance. So, but overall the recovery rate is approximately 90%, and patients will present with full recovery up in 1 year. Radiculopathy is myasthenia gravis is a chronic autoimmune disease, and a short version of etiology will be the fact that neuromuscular junction is affected. So there is no communication between motor neuron and the muscle cell, the innervated muscle cell. It's fairly young people disease. Someone in 20s or 30s can be affected, but again, it may affect anyone of any age. More common in women than men. So, as an autoimmune disease, it's caused by antibody-mediated destruction of acetylcholine receptors, and those receptors are located in neuromuscular junction. We don't know the exact mechanism, but it's believed to be related to abnormal T lymphocyte function, and most of the people with myasthenia gravis may present with thymus abnormalities as well. So what are the symptoms of myasthenia gravis? Patients will have less acetylcholine receptors in postsynaptic membrane, and what will happen from the each release of acetylcholine from presynaptic membrane will result with lower end plate potential. So what happens, the muscle will be presenting with weakness and fatigue when patient is trying to make a movement or just use that muscle. Most commonly affected, and for one of the first symptoms that will occur, that's extraocular muscles. And I remember from one of my clinical rotation as a student nurse practitioner, we seen the patient who was complaining of diplopia while driving, and the actual cause turned out that it was myasthenia gravis onset, and the gentleman was in his late 50s. And myasthenia gravis may be resulting in sudden exacerbation of symptoms, which may be called myasthenia crisis. So crisis is, when you're thinking about crisis, it's a condition when the ventilation affected, and this may happen after some kind of stress like emotional stress, infection, too much alcohol, or surgical intervention. Also, the treatment is the replenishment of acetylcholine in some way or shape. So the stress may result of the stress will be that acetylcholinesterase drugs are not enough. The patient, or another result will be that will be that patient isn't using enough drugs for treatment of this. Diagnosis given based on history and physical examination, but of course patient has to undergo to acetylcholinesterase test and immunoassays and acetylcholinesterase test will be using tensilon, which is one of the drugs that inhibits actual acetylcholinesterase, and tensilon is actually used for treatment. But what happened when, in this case, you give tensilon to the patient's symptoms are rapidly decreasing and patient is improving, like disease is gone at that point. So positive tensilon test will be diagnostic for myasthenia gravis, but also electrophysiology studies can be done, such as studies that will demonstrate like that muscles do not respond to stimulation of motor nerves. So treatments will be using pharmacological agents. There are two ways to do this, and first is immunosuppressive therapy, and again corticosteroids in this case, as well as medications that may be affecting cholinesterase, such as tensilon. So another treatment is when thymus gland may be completely removed, but it's somewhat controversial treatment because truly the mechanism is not known very well of the disease. So we will have a short overview of mental health disorders, and we'll talk about schizophrenia, mood disorders, and anxiety disorders in this part. Schizophrenia is a type of psychosis, and schizophrenia would be a certain collection of disorder that basically thought disorder. Psychotic individuals may have delusions, hallucination, impaired coping skills, and impaired communication. Swiss psychiatrist Eugene Bleuler used the term schizophrenia first time in 1911, but disease itself was first described and distinguished as a separate mental illness by Dr. Emil Kraepelin in 1887, but at that time the term was dementia precox, and when we read the description of the Emil Kraepelin's, when he describes the symptoms, we can see that these are the symptoms of schizophrenia. Even though we say that disease is recent, like the naming and diagnostic of the disease is recent, but of course through the centuries people had symptoms of schizophrenia, and people had schizophrenia even reviewing ancient sources starting from ancient Egypt. There are descriptions that are very similar to symptoms of schizophrenia. When patients starting experiencing symptoms of schizophrenia, most likely this will happen in relatively early age. It's teenage years to mid-20s, but it's uncommon if patient is having diagnosis of schizophrenia at older time, and if that happens, most likely the disease was undiagnosed earlier. But when patient develops the disease, the one thing comes to mind first, and it's loss of touch with reality. And the reality is replaced by imagined or fantasy reality. And by fantasy reality, it's not that reality is made up by the patient, but patient truly believes and has. Mood or affective disorders are the disorders that will involve emotions and the outward representation of the emotions. So when we're talking about emotions, we can call it mood, but the representation of the emotions we can call affect. So affective states are brief emotional feelings that are more or less visible and more or less manifested in the patient. Well, you can observe it in the patient, but mood is again a sustained emotional state. Again, common misconception and over-treatment in primary care and even in psychiatric setting, sometimes that not understanding the fact that people may experience times of sadness and times of extreme happiness. So when these emotions are appropriate to the time or to the experiences in life, we do not have a disorders. For instance, someone is grieving because of the loss of a significant other, and at this time we do not have a depression per se. However, if there are emotions not appropriate for the events, or they last inappropriate duration of time, or they are extreme in nature, the mood disorder can be suspected and diagnosed. And again, these are all relative terms in psychiatry, and appropriate or inappropriate, everyone reacts differently. However, the extremes can be diagnostic for mood disorders. And a good example is a manic depressive disorder, or as currently we call it, bipolar disorder, which alternates manic and depressive states. Depression is a prolonged feeling of extreme sadness and unhappiness, despair, discouragement, and we need to learn as healthcare providers to differentiate it from grief, which is realistic sadness related to a loss, to a personal loss. And loss can be a person and an animal, or patient may grieve because of the loss of the function or loss of a limb. But this is expected manifestation. Prolonged grief may become depression, however, if the person isn't able to cope with this, they may experience symptoms of depression. So there are genetic manifestations of genetic background for depression, as well as biological and environmental factors may certainly play a role. In some cases it can be one single factor, in other cases it's multifactorial, but however, nobody truly knows why some people would experience depression and the other may not. But we have some well-established causes for depression, but again, there is no clear picture per se, even though we treat depression relatively well nowadays and we know how to manage it, but again, we don't know exactly how depression occurs. So what are the causes of the depression? Will be, of course, genetic, heredity, personality, and again, personality can be tied to heredity and environment. Situational depression is a different type of depression, and this is a reaction to a situation. However, if the situational depression is, or reaction to the situation is prolonged, this may be cause of situational depression. Medical conditions can affect development of depressions, and for instance, the best example is hypothyroidism. People who develop hypothyroidism very often will develop depression and suicidal thoughts, and the symptoms are completely reversed when the patient is put on levothyroxine or Synthroid, and this is definitely a very strong correlation between hypothyroid state and depression. Substance abuse can be another source of depression. Dietary deficiencies such as folic acid and B12, and gender is a risk factor. Females are at more risk to develop depression. Age, elderly, socioeconomic status, the income level, and lower socioeconomic status may be resulting in depression. Extreme weight, again, can be resulting in depression and social isolation, and people who live alone, although the cause and the consequence here is difficult to pinpoint, because do they live alone because they are depressed, or they are depressed because they are alone? So patient, when they are experiencing depression, will experience feeling of rejection, helplessness, and feeling of being worthless. Disinterest in surrounding and disinterest in events that used to be pleasurable, and the word for it is ahedonia or ahedonia, because the patient experiences a loss of interest in previously pleasurable activities. Irritability, may even have suicidal thoughts, easily crying, and either lack of sleep or excessive sleep. Depression may occur during critical period in life, and it may affect growing up, like adolescence, or going through menopause also can be common, and also events such as retirement and entering into new work environment. So this all can affect the depression. So diagnosis, again, can be made by a thorough physical examination, and also questionnaires can be done, but physical examination, again, important, plus lab workup, because several conditions may be reflected as depression, again, as thyroid. So depression truly is the diagnosis of exception, because first of all, your job is to rule out an organic, a physical source of depression, then think about psychological, psychiatric illness. Besides the depression, the cohort of mood disorders can be also can include seasonal affective disorders, and again, the seasonal affective disorder is speculated to be related to circadian rhythms of the person, and the treatments usually is the same as the depression. However, some activities mimicking the longer duration of daylight or a day, bright light during the winter months may decrease the seasonal affective disorders symptomatology. Also, another disorder is bipolar disorder, which I wouldn't spend much time on it because it was well covered in undergraduate nursing curriculum. And just main thing here, in bipolar disorders, the genetic component certainly present, and the treatment may include mood stabilizers as well as antidepressants. Use of antidepressants in bipolar treatment is somewhat controversial because they may exacerbate the manic episode. So generally, the antidepressant medications work on somehow altering a pathway of communication between in the synaptic cleft, and different neurotransmitters may be affected by the work or by the action of the antidepressants. So here in this picture is its depiction of the work of SSRIs and how it occurs on the section D. The SSRI interrupt neurotransmitters relief and reuptake, neurotransmitter reuptake. So we do have in synaptic cleft sufficient amount of neurotransmitter which provides the halting of the depressive symptoms. There are three major classes of antidepressant medication: monooxidase inhibitors, which are currently very seldom prescribed because of the side effects and their possibility of adverse effects such as overdose can be very severe with this. Tricyclic antidepressants also almost not prescribed for depression, and some of them such as amitriptyline will be prescribed for the sleep disorders. So the mainstay of antidepressive therapy is SSRIs, selective serotonin reuptake inhibitors, and again, those medications work in the synaptic cleft, and they are inhibiting the reuptake of serotonin in this case. SNRI, it's some consider it as subcategory of SSRIs, but it's certainly a separate type of drug. They act quite similar by affecting the reuptake of neurotransmitter, but at this point they are covering quite several neurotransmitters, and they can cover norepinephrine, serotonin, as well as dopamine. So they may work not only on depression but also on disorders such as anxiety. Anxiety disorders is the condition that can be considered from deviation from normal. Normally, anxiety is a response to stress, and which induces fight or flight response in some individuals, but for others, anxiety may become a chronic problem. The individual may experience anxiety that is exaggerated or inappropriate to the situation. And anxiety before was called anxiety disorder as neurosis. It's truly the largest mental health disorder in the United States. Numerically, I mean, that's the biggest number of people affected. The cause of the anxiety disorder is again unknown with certainty, although genetic factors, stress, environment, biochemical alteration, and even physical causes can be pinpointed, and physical causes may be studied a little better, and in physical causes things like hyperthyroidism may affect development of anxiety. So anxiety has several types and different manifestations, but one of the extreme manifestation of anxiety disorder is panic disorder. Panic disorder is a state of extreme and uncontrollable fever, which we may call a panic attack. And it's usually very sudden onset and peaks in a few minutes, and the patient may experience a feeling of impending doom, and the patient would like to escape and run away from it. And also somatic manifestation may be present, such as diaphoresis, chest pain, tachycardia. Patient may experience nausea and dissociation. Generalized anxiety disorder, it's a feeling of excessive worry. It's a continuous state of mind to intense anxiety. It's not related to a specific event. Anxiety is called freeloading. It's a state of constant anxiety that may be leading even to somatic manifestations, again, such as nausea, vomiting, diarrhea, and dryness in the mouth, and again tachycardia. So all of this exaggerated states, and the patient lives basically on the edge, always being ready for some impending drastic events. Post-traumatic stress disorder is the development of the reaction as a response to psychologically stressful event that the person couldn't control, and it was outside of normal human experiences. Disorder is a relatively new addition to anxiety disorders, and it may be observed in war veterans, also victims who are victims of rape, abuse, or survivors of natural disasters. So people who deal with extreme situations, such as policemen and firemen, are at higher risk to develop post-traumatic stress disorders. And symptom can occur immediately after the event, or they may be staying dormant until several months after the trauma. Diagnosis of post-traumatic stress disorder, again, includes thorough physical examination to rule out other physical or organic conditions that may result in the development of similar symptoms. And but diagnosis is established also by confirming the history of symptoms and making sure that there are no other conditions are present. Treatment may include stress reduction, hypnosis, relaxation, exercise therapy, biofeedback, also medications. Treatment with antidepressants may be beneficial, or anti-anxiety agents. Some studies suggest that rapid debridement after being exposed to a traumatic event will have higher results versus debridement after a few days when the event occurred. Obsessive compulsive disorder is an anxiety disorder with two parts. Obsession is a repetition of a thought or emotion, and compulsion is repetitive act. And it affects the individual in a way that person cannot resist not performing that act or get rid of the thought. With OCD, the person is unable to stop the thought or the action, and behavior becomes some type of ritual, and thoughts or attempts to stop the ritual may lead to extreme anxiety. The behavior will become very time consuming, and in some healthcare providers, like hand washing, can become obsessive compulsive behavior. And also it may become disruptive to the job activities, such as someone who has a desk clerical job, obsessed with cleaning the objects or maintaining clean desk surface, or a nurse or a doctor who is obsessed with washing hands continuously. The treatment will include anti-anxiety agents, and sometimes SSRIs or even SNRIs may be prescribed for this, and results can be very reassuring with treatment with SSRIs. Also, psychotherapy at the same time will be also of benefit.